It's January 31st, 2025. This is the RoomNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. Pleased to be with you. RoomNow Live is coming up next weekend, 7 days away, February 8th and 9th in Dallas and online. It's probably too late for you to make arrangements to be in Dallas, although I highly recommend it. Listen to the end of the podcast and I'll tell you why. But you can still attend virtually. Go to roomnow.live to register. Today's news, we're going to start with a study about the risk of cancer in lupus. I'm sure you know that pretty much all the inflammatory diseases are a breeding ground for cancer. It's disrupted immune responses that, there's like that cartoon of normal immune dysfunction, cancer, and happy smiley face, and then a frown when you get to the end. Basically, it's a continuum. And the point being that chronic inflammation adds to cancer risk, and that's been shown for lupus. But in this Korean study of 10,000 lupus patients, 90+% of whom were female, they looked at the influence of immunosuppressive therapy on future cancer risk. And overall, amongst the 10,000, there were only 368 cancers in the cohort, which is still a higher than population risk, right? And the incidence there is 59 per 10,000 patient years. It sounds really low to me. And the most common was thyroid, breast, gastric, colon, and cervical cancer. And certainly all of that being colored by this predominantly female population. But when they looked at the role of immunosuppressives, comparing those on and not on immunosuppressors, there was no additional risk. And I think that's always a concern. That's always the confusion. Is it the drugs that we're using to control inflammation that cause cancer, or is it the inflammation and disease itself? I like the latter 9 times out of 10. I mean, there are some drugs like cyclophosphamide, chlorambucil, etc. Multiple chemotherapies make for a higher risk of cancer due to drugs. But I think that this is a clarity kind of presentation. I like the clarity in this particular study. It's a study of clinically suspect arthralgia patients, and it was an evaluation of the literature. So they looked at 39 imaging studies done in patients with CSA or preclinical RA, whatever you want to call it. And they wanted to see what the value of imaging was at this stage of the disease. Of course, they have that label because they don't have synovitis. They just have arthralgia. What if you do imaging and you find synovitis, you find synovial fluid, you find bone marrow edema, or you find tenosynovitis on Doppler ultrasound? I said here before, and I still believe, that Doppler ultrasound findings of tenosynovitis is highly predictive of future progression to disease. Well, in these almost 40 studies, they showed that the predictive value of either ultrasound or MRI, there were 12 MRI studies, 26 ultrasound, there was a few others that I'm not going to count, was variable and not as great as you want, largely due to a low sensitivity. And when they looked at those modalities, they found a low sensitivity for ultrasound 37%, MRI 45%, but high specificity, ultrasound 90%, MRI 84%. So which would you do? I like ultrasound because it's easy, and if you're experienced at it, and finding tenosynovitis or synovitis should make you worry a little bit more. But I think this is a sobering evaluation, albeit a meta-analysis that says that these are not the be-all, end-all, and maybe these tools should be reserved for large cohort studies. The NIH did a really interesting analysis. I pulled this up because I was writing the chapter in Harrison's on the evaluation of the musculoskeletal complaint and found the data that there are approximately 127 million people in the United States with musculoskeletal disease or arthritis. But in this study that was published, and this is interesting if you're a researcher and dependent on NIH funding, they looked at the burden of disease in the population in the United States and NIH funding for those diseases. So they looked at 60 different diseases, and overall, the study showed a very good correlation of NIH funding with the burden of disease in our population, except for musculoskeletal disease, where it was woefully deficient. So they matched up the population prevalence of these disorders and how much and then matched up how much of the, what is it, in 2023, $980 billion, almost $1 trillion being spent on research, and whether it matched up. Did not for osteoarthritis. Lowest in funding was neck arthritis. This was really surprising. So 100% would be appropriately funded. Neck pain was 0.83%. What? Low back pain, 14% of what it should be. Osteoarthritis, 35% what it should be. And RA, about 66% of what it should be. So again, low back pain itself is about $500 million less than it should be based on the prevalence of the problem in the United States. To rectify this problem, the NIH would have to increase its funding 120-fold for neck pain, 7-fold for low back pain, and 3-fold for osteoarthritis. This is important to all of us in practice and especially at academic centers and those who are getting NIH funding. We need to pitch for greater funding and for the advocacy necessary to get that funding. An NHANES study looked at 2,200 RA patients and looked at the impact of dietary modification. This is not a surprising report, but it strengthens what we said before. The association is with diet and all-cause mortality. And they looked at two different measures, the healthy eating index and the low and the dietary inflammatory index. Healthy eating index, when that's high, that's like, a Mediterranean diet, a healthy diet, a DASH diet, ones that have been shown to improve all outcomes, cardiovascular and mortality. The dietary inflammatory index, when that is high, that's not good. That's an inflammatory diet. And we know that that's not good. And anti-inflammatory diets, Mediterranean diets are good. So they found a high healthy eating index and a low dietary inflammatory index had an overall reduced mortality. So these were the best possible diets. Really healthy and low inflammatory diets reduced mortality by 30%. And I think that's a number that you can quote. That if you eat healthy, meaning, and let's fish, vegetables, fruits on the healthy eating index, and avoiding, Burger King and French fries and waffles with lots of maple syrup and butter, that's what I wanted for breakfast today, but I didn't have. But nonetheless, because I'm going for that, low dietary inflammatory index, that's where you don't want to be. But advocating for the healthy diet, the low inflammation diet, you can tell your patients you can lower your risk of death by 30%. That's equivalent to what you would get if you were on a GLP-1 agonist. That's powerful data. More powerful data comes from the German database that looked at 16,000 patients in their database of rheumatic disease patients. And what they showed, they were looking at work participation. That's the new word, participation in work. It's not enough to go and do a good job at work. You just have to participate and you get paid. And that's a measure of success by at least this study. A little worrisome. But again, employment is the issue here. And absenteeism, unemployment, and disability were the main factors. They showed that since 2010, for about a 10-year period, all these parameters went up in rheumatic disease patients. So, and this is the National Database of German Collaborative Arthritis Centers, looking at people under age 65. During this time period, RA employment went up from 54 to 68%, PSA from 58 to 72%, a 14-point improvement. Scleroderma, 47 to 66, almost a 20-point improvement. Lupus, 48 to 60, and AxSpA, 65 to 73. Absenteeism also decreased significantly for RA, AxSpA, PSA, lupus, scleroderma, and ANCA-associated vasculitis. So we're doing something right, are we not? However, yet as always a but, our patients have not reached population employment rates, population absenteeism rates, and disability rates. So we still have a ways to go. Better control of the disease makes for happier patients. A sub-analysis of the Stop Gout study that was published last year, Jim O'Dell and a bunch of others were on that study. They looked at a sub-analysis of patients in that gout study where patients were either receiving Febuxostat or allopurinol as urate-lowering therapy. They looked at patients who had chronic kidney disease. And they showed that the good news was that in CKD patients using either urate-lowering therapy, you were able to achieve your urate goal, and that the protocol was driven by achieving your goal of 6 or less, or 5 or less if you had tophi. It was achieved in 80% in the trial. That's really good. It should be 100%, but it's still really good because even studies where people say they treat the target in gout, only like 30, 40% of rheumatologists get to the target goal. Nonetheless, they found achieving the goal, and even though they looked at gout flare rates in the second 6 months, because they're high in the first 6 months when you start urate-lowering therapy, they still had 30 to 40%, and they actually had less gout flares with allopurinol than Febuxostat, 32% versus 45%, significant favoring allopurinol. And there were some cases of acute kidney disease, but they didn't go into it very much. We do know that both these drugs can be used in patients with CKD. Most of those AKIs were allopurinol hypersensitivity. What you need to know about this study was that the mean dose achieved in the trial was about 400 milligrams for allopurinol and about 60 milligrams for Febuxostat, meaning that I think some of the Febuxostat was a little underdosed, but it was protocol driven, right? So this does tell you, like we talked last week, that you can use these urate-lowering drugs in patients with renal insufficiency with really low risk. And I think that's important. And the other important thing is, get to your target and escalate your dose and be on effective doses. We should be on higher doses. That we treat patients with gout that are problematic means that we should not be using, 300-400 milligrams of gout a day. We should be using it as high as possible. Another study from Oren Traum and Brian Lamoureux looked at a real-world experience of starting methotrexate in patients on Pegloticase. Now, what's different about this study, we do know that giving methotrexate with Pegloticase lowers the risk of toxicity and flares and whatnot. But in this study, they had 11 uncontrolled gout patients on Pegloticase already, and they started the methotrexate secondarily, right? So they were not doing well on Pegloticase, and would methotrexate make them better? Only one of the 11 patients, or 9%, benefited from adding methotrexate. The take-home point here is if you're going to be using methotrexate with Pegloticase, it's got to be there from the start, with the initiation of Pegloticase. And there are other drugs that you can use, and you're using methotrexate so as to reduce the amount of anti-Pegloticase antibodies. You could use azathioprine, you could use mycophenolate, you could even use Febuxostat, although I would not recommend that because you're monitoring the uric acid levels as a measure of whether you're getting into trouble or not. Anyway, think about this when you're starting Pegloticase. Last bit on gout, Febuxostat, made by Takeda, marketed as Uloric, has been discontinued in the United States. That doesn't mean that Febuxostat is not available. It means that it's now on generics, and there are generics that are available. And that's important. Takeda made the decision, and this was discovered on an FDA drug shortages list just recently. They made the decision based on the generic availability, dropping sales, continued concerns about cardiovascular safety for Febuxostat. It's written about a lot, really since the beginning of the Febuxostat trials, the FACT trial, the APEX trial, the CONFIRMS trial, which was done to figure out whether there's an increased cardiovascular risk with Febuxostat. It wasn't. And then the CARES trial, which said, maybe it is. This is always bantied about. To me, this is like the cancer risk with the drugs we use for RA. And is the cancer from RA or from lupus, or is it from the drugs we use? It's always from the disease. And in this case, it's the same thing, in my opinion. these drugs don't cause heart attacks and bad cardiovascular outcomes. It's the gout, does it not? I mean, gout is a horrible comorbidity machine. And I must say, I can think of 3 patients who I wanted to put on Pegloticase. 2 of them died before I could get them on Pegloticase from cardiovascular events. And one of them didn't die, but while waiting, had an MI and was hospitalized, and then didn't want to do it because cardiovascular side effects were in the list of side effects. This is really complicated, but not for you and I, because we understand the relationships here. You can still get Febuxostat at your local pharmacy. It's going to be generic. There was a Chinese study this week that was published, 135 patients who had infectious sacroiliitis. Pyogenic sacroiliitis was most of those cases, about 70%. The 21% were TB sacroiliitis, and 13% were brucella sacroiliitis. This was their experience, a collective experience between 2008 and 2020, and they looked at everything that they did. The important points here is to make this diagnosis, you need to do a CT-guided biopsy of the SI joint. 87% of patients who had that done had a positive result yielding the pathogen that changed the course of therapy. Very important. The other interesting report, obviously these people, not all of them have back pain, but most of them have back pain, that 51% of these patients met ASAS criteria for axial spondyloarthritis. So you should be worried about this, right? Back pain was lower in patients with pyogenic sacroiliitis, only 19%, than with tuberculosis and brucella, where it was 40 or 65%. The MRI findings in these people was bone marrow erosions and bone marrow edema. SED rates were high, but not always high. They were generally about 50 millimeters or so. And it was higher in pyogenic and tuberculous sacroiliitis than it was in brucella, where it was only about 33 as a mean. But the point that you really got to remember, 2 points, I guess, really is do the CT-guided biopsy of the SI joint with suspicion. And I think you should think of suspicion when it's unilateral, when it's, although these cases were often bilateral, and when there's other systemic features, including fever. And the other point is that these people might look like axial spondyloarthritis, and you need to be wary of that. Another cohort study of patients with JIA and uveitis, 81 patients who were on adalimumab, and they randomized them to drug withdrawal. So half of them who were doing well with their adalimumab as far as their joints and as far as their eyes, they either kept them on adalimumab or they did switch them to placebo. In follow-up, 14% of the adalimumab continued patients had a flare of either their joints or their eyes, whereas almost 70%, 68% on placebo flared. So if you withdraw therapy after a year, you have an 8-fold higher risk of treatment failure. So I guess the bottom line is maybe only 1/3 of patients who have stable JIA uveitis on adalimumab can safely discontinue without flaring their eye or their joint problems. What? I found this patient also, this is a study that I found really interesting. It's from the Swedish National Registries, and they looked at 40,000 18-year-old Swedish males who, I guess in that time in their life, they undergo comprehensive examination. And I guess it might be for future service, military service, whatever. And that happened in 1969, 1970. And they followed these people until age 60. And they wanted to see what their lifestyle practices were as far as future disease outcomes. They were looking at cardiovascular, respiratory, and musculoskeletal disease. And they found that a few things that you would probably expect, that if they had a higher BMI, it increased the risk of musculoskeletal disease, cardiovascular disease, and respiratory disease somewhere between 12 and 22%. if you had, as a young adult male, okay, higher muscle strength and good cardiovascular fitness, that too was associated with an increased risk of, no, not cardiovascular and respiratory, that was lower. But musculoskeletal diseases were higher overall at an 8% risk, but it was largely osteoarthritis, a 23% increased risk, back pain, 18%, and shoulder disease, 27%. So, and of course, as you would expect, smoking was not good when it came to all of these, musculoskeletal, cardiovascular, and respiratory disease. What they were really talking about here is the potential for damage, and, being more fit might come with a risk of damage, and better instruction and guidance by clinicians might avoid that going forward. I've got two Ask Cush Anything questions. One was an email question from Mariah Mansour in Delaware. She asked, because I often teach about how to use methotrexate better, she asked, how much vitamin A do you give for patients who have nausea with methotrexate? And how much dextromethorphan do you give for the lethargy associated with methotrexate? So vitamin A usually comes as 8,000 units. I know you think that someone who has nausea or ulcers, you increase the folate, that's going to help. It doesn't, okay? But you're treating yourself if you think it does. Vitamin A does, and I learned this from, again, a great pediatric oncologist, Bart Kamen. He showed me the experiments where if they took methotrexate and they poured it down the mouth of a rat, they got a hemorrhagic enterocolitis. If you pre-treated the rat with vitamin A, they didn't get it. I'm using vitamin A. Vitamin A comes 8,000 units, and you take one pill a day to prevent the mucositis and maybe the nausea associated with methotrexate. Because sometimes the nausea might be an upper GI effect as opposed to a central effect on the brain, and it does work there too. But some nausea and queasiness is a central effect, and the brain stuff, the lethargy, the methotrexate blahs, the blurry vision, sexual dysfunction, even nausea, the queasiness, is treated by dextromethorphan. Dextromethorphan blocks NMDA receptors in the brain. NMDA receptors get taken up by excitogenic amines, breakdown products of methotrexate, homocysteic acid, affect the brain by binding to NMDA receptors. You can block that with dextromethorphan, Robitussin DM, but that's syrupy, goopy, and yucky. I use Mucinex DM, which has 30 milligrams or 60 milligrams of DM. 30 milligrams is enough. And you take it only with the methotrexate. Vitamin A every day for the mucositis, Mucinex DM for the CNS effects, only with the methotrexate. So you take it with the methotrexate. I give methotrexate at night. You'll take one Mucinex DM, take another one in the morning, and another one the next day. You need at least 2 doses to get the effect, and 3 in some patients. Again, I think it's the best way to do this. Let me see. I have another one here from New Jersey. Ken. My goodness. Ken from New Jersey, I'll look this up, asked me the question about, oh, here we go. It's Ken Wasser. Let's listen to what he has to say.
This is Kenneth Wasser, rheumatologist in New Jersey. The St. Barnabas system is offering low-dose radiation for recalcitrant osteoarthritis. Curious about your take on this modality. Thanks.
Well, I can sum that up pretty quick. That's a special kind of stupid, is it not? Radiation therapy for osteoarthritis. There is a long literature about radiation therapy in arthritis in general, especially inflammatory arthritis, where it was felt to potentially be anti-inflammatory and immunomodulatory. You only hear about this. None of us rheumatologists are writing about this. Any rheumatologist that actually has done any research on this shows no benefit. And it's a placebo effect or regression to the mean. That was proven in a 2022 Lancet article with long-term follow-up. It doesn't work. It shouldn't work. It's a money grab. shame on the people who are advocating this. If you're one of them, let's arm wrestle about it at the next meeting, because I think it's goofy. Again, just look at the history of what's going on in osteoarthritis and treatment. Nothing works. The NIH is underfunding it. They need at least a threefold increase in their funding to catch up with the population-based need, and there certainly is not any funding. Sorry about that. I went a little overboard. Talking about overboard, RoomNow Live, if you got to come to this meeting, because it's going to be a great meeting. Look at the program. It's stellar. We have, but the hidden gem I talked about last week, the keynote speaker, Dr. Charity Dean, she's going to just amaze you. But after that, we've got a reception. Yeah, that's nice. A few drinks, some mac and cheese and roast beef and whatever. But after that, we're doing karaoke. That's right. Rheumatologists do karaoke. This happens, I know a bunch of you that go out after ACR and EULAR or during the meeting, and you're out all night singing and showing up late for the great debate the next morning. So we're going to do it at this meeting, and we're going to have fun, but it's not just karaoke. What's Kush going to sing? It's probably going to be Warren Zevon's Werewolves of London or Garth Brooks' Friends in Low Places. Blame It All on My Roots. I showed up in boots. Anyway, but the better part is it's Gong Show Karaoke, meaning we're going to have the audience members on stage as the judges, 3 of them. And if they don't like the presentation, they're going to gong them off stage just like they did in Chuck Barris's Gong Show in the 70s and the 80s. Look it up if you weren't born in 1970 or weren't alive in 1970 or 1980. Gong Show Karaoke, it's going to be a ton of fun. We'll see you at RoomNow Live. Take care.